Hello everybody. The topic of our lecture is prognosis and planning the treatment of patient with periodontal disease. This is the question of our lecture. Definition and types of prognosis. The next, prognosis of the condition of individual teeth. Stages of planning the treatment of periodontal diseases. This is the plan. 3 questions. What is the medical prognosis? Medical prognosis is a prediction of the illness or disease outcome based on knowledge of the development regularity of pathological process. Or prognosis is a prediction of the probable cause and outcome of a disease and the likelihood of recovery from a disease. Russian famous Dr. Astromov said, "Only the knowledge of the organism particularities gives grounds to predict this or another development of the diseases." Now you can see the mathematical image of prognosis, and this is a diagram that displays major or damaged factors or prognosis criteria on periodontal diseases. Now you can see 4 different clinical cases depending on the different stages of pathological process. And so each patient has his own prognosis, his own planning of treatment, and his own result of the treatment, of course. Now you can see the case before treatment, and I have a question: what is the diagnosis and prognosis of this patient? Clinical picture before and after 2 months of treatment. Diagnosis: this is hyperplastic gingivitis at the metastasis stage. And now you can see the good prognosis, of course, after 6 months treatment. And this patient has a good treatment and good prognosis. The next, the involvement of each tooth in the pathological process. You can see 2 clinical cases now, and it is necessary to determine the prognosis of the pathological process in each case. In the first case, the pathological process is localized within the marginal parts on the gum. There is a suspicion that there is a systemic pathology that is manifested in the oral cavity. That's why this is in this first case the prognosis will be poor. On the second of the case, you can see that the front part of the all gum involved in the pathological process. All gum. This is a banal inflammation, and this banal inflammation is eliminated by removal plaque. Good hygiene in the future. In this case, the prognosis will be good. The prognosis in the first case is poor. Of the second case will be good. There are 2 types of prognosis: prognosis of the disease and prognosis of the patient. Sometimes the prognosis of the disease and prognosis of the same patient may not be the same. Sometimes they are similar. There are 2 types of prognosis: good and poor. Good prognosis when the diseases will go away or the pathological process can be stabilized. The poor types of prognosis, when the regular courses of periodontal treatment do not allow achieved stabilized remission, and tooth loss happens in the future. Let me go into some more details about patient prognosis. Now you can see the prognosis criteria of the about patient prognosis, age, duration of the diseases, use of tobacco, stress, genetic risk factors, cardiovascular diseases, diabetes, pregnancy, poor oral hygiene, the patient organism resistance reactivity, constitution and personality traits, allergy to medicines, professional risk, social economical condition. How age affect prognosis? This is the first prognosis criteria, age. How age affect prognosis? As people age, their risk of developing periodontal disease is increasing. Over half of the adult population has gingivitis, less severe form of periodontal diseases surrounding 3 to 4 teeth, and nearly 30% have significant periodontal diseases. In a study of people over 70 years old, 86% had at least moderate periodontitis or a severe form of periodontal diseases, and over 1/4 of these, 86%, had lost their teeth. The next prognosis criteria, duration. How duration of the diseases affect prognosis? Adults have a better prognosis than young people. If the patient is young, the pathological process is faster and more malignant. Reparative process in young people are some complete compared to older regeneration. The patient organism resistance reactivity. Some patients have a marked positive effect shortly after the treatment beginning, and other patients have little effect regardless of the treatment intensity. You can determine the prognosis only after initial pre-treatment, when the doctor determines the response of the body. Constitutional and personality traits. This is a very important, a tendency to focus on fixing the painful sensation contribute to a more severe the prolonged disease course. You can see the clinical case of the periodontal tissue in a patient 35 years old. You can see the poor condition of periodontal tissue, and this woman has no periodontal treatment. Without periodontal treatment, regular courses, without regular courses. And now you can see a progression of the pathological process in the periodontal tissue. Of course, this is a poor prognosis. In radiographs, you can also see the progress of the alveolar bone destruction. And look carefully, yellow square, middle prognosis, replaced by red, poor prognosis for 3 years. Only 3 years we can see the progress of alveolar bone destruction. The clinician wonder, how can we predict the speed of periodontal diseases progression in each patient, and what is necessary to do to improvement of the stage? In the Journal of Clinical Periodontology, published an article of American Academy of Periodontology statement on risk assessment. The American Academy of Periodontology believes that dentists' use of risk assessment will become a component of all dental and all periodontal evolutions, as well as part of all periodic dental and periodontal examination. Periodontal disease caused by dental plaque. If the success of treatment is taken as 100%, only 70% depends on the doctor, on the doctor. And 93% depends on the patient who brush the teeth twice a day or not brush the teeth. The prognosis depends on the level of inflammation in the process. And banal inflammation is eliminated by removal plaque, good hygiene in the future. Now you can see the case of good prognosis. Why? Because this is a banal inflammation. In the patient will be removed plaque, will be good hygiene in the future. In this case, the prognosis will be good. In other situation, if there is a systemic disease, when remission can only be temporary, and it is very difficult to work with such patient with systemic diseases. There is a systemic pathology that is manifested in the oral cavity. For example, blood diseases, diabetes, and other systemic diseases. And of course, in such cases, the leading role in the treatment belongs to the doctor internist, for example, endocrinologist, hematologist, and others. Prognosis of periodontal diseases. All prognosis criteria divided into the risk assessment or progression of periodontal disease: low, middle, high, green, yellow, red. Now you can see low green level risk of assessment of periodontal diseases when all criteria are in the low section of the diagram. This patient has prognosis criteria such as 4 segments with periodontal pockets of 5 mm and more, 2 missing teeth, and alveolar bone loss to the age 0.25. This patient without the dental facial deformation or malocclusion and systemic diseases. Patient doesn't smoke. This patient has low green level of risk assessment. The next case, prognosis of periodontal disease, middle risk of assessment. Middle risk is determined if 2 parameters are in the middle section, but not more than 1 parameter in the category of high risk. Now you can see the patient, 43 years old, has prognostic criteria such as 6 segments with periodontal pockets of 5 mm and more, 4 missing teeth, bone loss age 0.7. This patient with dental facial deformation and malocclusion and systemic diseases, this patient has osteopenia, low bone amount, and patient doesn't smoke. This is a medium risk assessment, yellow risk assessment. There is a high risk assessment, red risk of the periodontal diseases, when the patient has the most prognostic criteria in all limits. The patient has prognostic criteria such as 20 segments with periodontal pockets of 5 mm and more, 4 missing teeth, ratio of the LVL bone to the H1.0. This patient with dental first cell deformation and without systemic diseases, and patient sometimes smokes. And now we see high risk, red color of the risk. And of course, this is a poor and this is a red bad prognosis. The patient has prognosis criteria such as diabetes type 2, uncontrolled, and genetic predisposition. If there is an uncontrolled systemic diseases, then remission can only be temporary, and it is very difficult to work with such patient with systemic uncontrolled diseases. There is a systemic pathology that is manifested in the oral cavity. For example, diabetes and other systemic diseases. Generative aggressive periodontitis. This patient has high red level of risk assessment, and if the patient will not control diabetes, it will soon lose teeth. The next, tooth level risk assessment. I'd like to pay attention for prognosis of the individual tooth depending on the presence of occlusal trauma, the level of the LVL bone loss, the presence of the periodontal pockets, the level of frenulum attachment, degenerative changes in the pulp, and the amount of tooth in the roots, amount of the roots in the tooth. How the presence of occlusal trauma affects prognosis? If we determine an occlusal trauma in the oral cavity on patient, it aggressively destroys periodontal diseases, which lead to vertical resorption. Vertical resorption. Now you can see vertical resorption, and the formation of intraosseous pocket. This is a intraosseous pocket. The presence of occlusal trauma destroys the periodontal tissue aggressively, resulting in the vertical resorption and intraosseous pockets. The dentist should take into account of remaining bone. The prognosis is good when there is not a large loss of the bone tissue. In this case, there is a tendency to the loss of the bone. And of course, the prognosis depends on the correct treatment planning. Now you can see the oval-shaped effect. This oral shape effect is associated diabetes. Maybe in this case, in this patient has diabetes. Another important thing that I want to say about the presence of intraosseous pockets. This is the intraosseous pockets. Dentists make the prognosis on the basis of intraosseous pockets present. The depth of the pocket is not the main factors for the prognosis, but the location of the base of the pocket is much more important. Much more important. Localase of the base. Prognosis of endodontical treated teeth. The prognosis of endodontical treated teeth is little different from the vital teeth prognosis. The periodontal reattachment is likely to occur in vital than non-vital teeth because the vital tooth root recovers the attachment better. Multi-rootous and single-rootous teeth diagnosis. The furcation involvement in multi-rooted teeth is a rather poor situation and poor prognosis, of course. Maintain hygiene measures with such teeth is very difficult when the furcation involved in pathological process. That's why the prognosis will be bad, will be poor. Two clinical cases you can see, and pathological process in first localized in the marginal parts. The prognosis will be poor. In the second, the frontal part of the whole gum involves the pathological process, is the banal inflammation, and of course prognosis will be good. I will show you how to determine prognostic criteria using the example of prognosis of endoperiodontitis. Endoperiodontitis is difficult to treat, so you need to predict development at the beginning, and when plan the right stage of treatment. This is a combined lesion of endodontium and periodontium associated by inflammation and destructing changes. And you see before and after treatment this case. The diagnosis is chronic, localized, simple endoperiodontitis, moderate severity of tooth 1.3. Treatment include endodontic treatment and periodontal treatment, of course. The prognosis of periodontitis including 9 prognostic criteria of developing endoperiodontitis. Number of segments with pocket depth 5 mm and more, electric pulp test, destruction of the apical part of periodontium, decreased height of the intra-alveolar septum, ration of the alveolar bone loss to the age, gingival index GI, bleeding on probing, tooth mobility, habits, tobacco smoking. And all prognostic criteria are divided into 3 levels of risk assessment: low, medium, and high. You can see a low risk assessment of development endoperiodontitis of the tooth 1.4. And you can see that the color is green, which means that the risk assessment is low. All prognostic criteria are low, excluding 2 criteria for the gingival index GI, 0.9 inflammation of the gums, and the presence of tobacco smoking habits in the parts, which are in the medium probably category. You can see a low risk assessment of development in the periodontitis to 1.4, and you can see the color is green. That means that the risk assessment is low. The next case, medium risk assessment of endoperiodontitis. You can see the picture, clinical picture with migration, pathological migration, and endoperiodontitis tooth 3.1. Most prognostic parameters criteria are in the middle range. In this case, 2 parameters are in the category on higher risk assessment. This decreased length of the intra-alveolar septum and ratio of the alveolar bone loss to the age 1.1. This is the medium risk assessment. In radiograph, you can see endoperiodontitis of tooth 3.1, and in this case 2 parameters in the higher risk assessment. high risk assessment. You can see the radiogram, and you can see two parameters in the category of high probably, decreased height of the intra-alveolar septum, ratio of the alveolar bone loss to the age 1.1. The medial risk assessment is determined of 3 or more parameters in the middle range, but not more than 2 parameters in the high probably category. You can see a patient with a high risk assessment of developmentus and the periodontitis 3.7. All prognostic criteria are in the high risk, except the past of the habits of smoking, tobacco, which in the medium probably category. Smoking, tobacco, only medium. All criteria on the high level, better level. A high risk assessment has detect in the presence of more than 2 high parameters. Here we see this patient has 7 high parameters. That's why this is a poor prognosis. The next part of our lecture, this is the planning, treatment of planning. After determining the prognosis, the treatment is planned. The first stage is always initial treatment or preparatory treatment. The second is a re-evolution of periodontal tissue. In periodontal indicator are normal, and if the patient has malocclusion and dental deformation, we are planning orthodontic treatment. If the patient has defects in teeth and dentition, we plan prosthodontic treatment. If necessary, we also plan surgical treatment of periodontal tissue. And the last step, always supportive therapy or maintenance therapy. Interdisciplinary treatment includes periodontics, prosthodontics, orthodontics, implants, adhesive dentistry. It is very important to answer this question. What is important? What is difficult? And do we also need all? What is important? Of course, that the patient's expectation and the doctor expectation were the same. If it is necessary to control inflammation in the tissue of the periodontium, never ever start treatment in a patient with interdisciplinary complex treatment needs without established optimal control of inflammation. Never ever start treatment if the patient had poor condition in the periodontal tissue. Inflammation in the tissue, never start the patient, never start to fix orthodontic treatment, never start fixing implants and other adhesive restoration and other dentition. The next role of occlusion. A good understanding of the role of occlusion based on biologically sound and update concepts. It mandatory detail with complex interdisciplinary starting treatment only to active a morphological ideal concept of occlusion may be tricky. And the next treatment sequence, each step in interdisciplinary treatment should make the following step easy or more effective. More effective. The first stage of planning, this is a preparatory treatment. The plan of treating periodontal diseases is developed after initial treatment or preparatory treatment. The initial therapy consists of the eliminating of etiological factors and particularly irritation factors such as dental plaque, iatrogenic factors, and potentially harmful habits. This stage is called initial. It means that most important and effective method of periodontal treatment. Hygiene measures consist of dental plaque removal up together with the patient motivation about the need for these activities, teaching oral care, control of the plaque present, and growth. The next elimination of iatrogenic factors in the oral cavity. If we necessary, we use temporary splinting. Temporary splinting is done in the patient has very mobile teeth. The next, if the patient has bruxism or another parafunction, the next stage, elimination of parafunction. If the patient has bruxism, you cannot continue to plan treatment. You must first eliminate bruxism with a splint. Splint is very necessary to do in this situation. And the next, manipulation on the gingival wall, curettage. Now you can see three procedures are very important in the periodontal tissue: hygiene measures, dental plaque removal, oral hygiene motivation and training, and control of the dental plaque growth. The patient has poor oral hygiene, therefore it's very necessary to carry out hygiene measures and motivation. 3 hygiene measures: dental plaque removal, oral hygiene motivation and training, and control of the dental plaque growth. A manipulation of the gingival wall. Initial therapy included manipulation of gingival wall or elimination of proliferation epithelium lining on the gum by the curettage method. Curettage is the removal of wounded epithelial line of the gums. This method gives short-term effects because the epithelium of the periodontal pockets quickly regenerated. Elimination of iatrogenic factors in the oral cavity. During the elimination of iatrogenic factors, you need to detect poor class 2, class 4, class 5 dental fillings with bad contact points and denture with a long crown and traumatic intermedial part. Re-evolution of periodontal disease. The next step, this is the re-evolution, which evaluates the reaction of periodontal tissue to the action of the preparatory or initial stage. In this stage, you should evaluate the oral hygiene of the patient, evaluate of the condition of the gum, the depth of the periodontal pockets, and the condition of periodontal microcirculation. 4. Index assessment: oral hygiene, gum condition, periodontal pockets depth, microcirculation status of periodontium. The next stage, of course, orthodontic treatment. Orthodontic carry out orthodontic treatment in case with malocclusion. It is important to obtain quality prosthodontic treatment, implantology, splinting of teeth, and some surgical treatment without the correct position of the teeth and without the removal of malocclusion. That's why orthodontic treatment provides the functional stimulation necessary to maintain the periodontal tissue health, besides getting the occlusal correction. If the patient has defects in teeth and dentition, the dentist does prosthodontic treatment and splinting the teeth. After orthodontic treatment, we use splinting the teeth, and of course this is a non-removable splinting, and you can see removable splinting too. Removal or non-removable splinting. The next stage, surgical treatment. Surgical treatment is aimed at eliminating the inflammation of the periodontal pockets, the factors caused them, and the restoration of the gum and mucogingival relationships. Now, in this case, you can see the surgical treatment, flap surgery. Flap surgery, now you can see. And periodontal pocket is filling osteographic granules. Radiogram, you can see before and after surgery. Now you can see the periodontal pockets also is filling osteographic granules, picture after surgery. And final obligatory stage, supportive therapy. Supportive therapy is focused on regular oral hygiene monitoring and detection of dental caries, monitoring of occlusion, microcirculation status in the periodontium. And the aim of supporting therapy is maintain the achieved positive result and to prolong oral health. Physiotherapy is one of the most effective methods of microcirculation normalization in the periodontal diseases in supportive therapy. This is the end of our lecture. Now you can see two questions. What stage of treatment planning and what stages of preparatory treatment? Please answer the question. Thank you very much for attention.